Okay, let's unpack this. Welcome to the Deep Dive, your shortcut to being well-informed. Today, we're diving deep into immune responses and transplantation. We're pulling crucial insights from Lewis's medical surgical nursing, our mission. Really simple. Distill the most vital concepts, link them to the real world of nursing, your world, and make sure you're equipped with knowledge that truly matters for patient care. We are talking about the body's incredible, really intricate defense system, the immune response, and what happens when it goes right or sometimes significantly wrong.
It's fascinating, isn't it? And, well, understanding the immune system is just so foundational for every nursing student. It really is. It's the thread connecting so many concepts you'll see every day. Things like inflammation, infection, tissue integrity, complex diseases. We'll explore not just what happens, inside this system, but really why it matters so much for the patients you're going to be caring for.
Absolutely. So let's kick things off with the core functions, the three pillars of immunity, we could call them. First up, defense. This is your body on guard, constantly watching for invaders, microorganisms, pathogens, foreign stuff. It's that proactive shield stopping infections.
Right. Identifying and attacking.
Exactly. Then, pillar two, homeostasis. Think of this like meticulous housekeeping for the body. It's clearing out damaged cells, getting rid of old cellular debris, basically keeping the internal environment stable and uniform.
Cleaning up the clutter.
Yeah. And finally, surveillance.
Yeah.
Our cells are always replicating, and sometimes, mistakes happen. Mutations. The immune system patrols, finds these mutated cells, and ideally destroys them before they turn into something bad, like cancer.
And right at the heart of that defense and surveillance, you've got antigens. Basically, an antigen is anything that can trigger an immune response, usually proteins, but sometimes other big molecules too, like polysaccharides. What's really critical for you as nurses to get is that every cell in your body have unique self-antigens. Your immune system is normally tolerant to these. It knows not to attack itself.
Okay, so it recognizes friend from foe.
Precisely. That self versus non-self recognition is absolutely fundamental for protecting you without causing, friendly fire.
That distinction is everything. So how does the body actually do this? We have two main strategies, right? Innate versus acquired immunity. Innate immunity. That's your built-in first-line defense, the rapid response team you're born with.
Ready to go.
Yeah. It's nonspecific, reacts the same way to any invader, and it kicks into action really fast, within minutes. Think neutrophils, monocytes rushing in, like the general alarm.
Right. No prior exposure needed.
But then, for more, let's say, targeted long-term protection, we've got acquired immunity. This develops over time. You learn from exposure. It can be active or passive. Active acquired immunity means your body makes its own antibodies or sensitized cells. This happens naturally, like after you recover from chickenpox, right? You get immunity.
Big, long-lasting immunity, usually.
Or it happens artificially through vaccines. You get a weakened or inactive piece of the antigen, and your body learns to fight it. Takes time, but it lasts.
Okay.
Then on the flip side, there's passive acquired immunity. This is where you get antibodies from somewhere else. Naturally, that's like maternal antibodies crossing the placenta or through breast milk. Gives the baby immediate but temporary protection.
Temporary, yeah. Because the baby's system didn't make them.
Exactly. And artificially, that could be an injection of gamma globulin if you've been exposed to something specific, like hepatitis. Quick defense, but again, short-lived. The key takeaway, maybe like described in Table 14.1 in Lewis's, is passive is instant but temporary, active takes time but lasts because you build that memory.
Right. Makes sense. And to really grasp these responses, we need to know the key players and where they hang out, their headquarters. So the lymphoid organs, this is where immune cells are made, where they mature, and where they do their work. You've got the central ones, the thymus gland and bone marrow. That's lymphocyte production and maturation central.
Okay, the training grounds.
Kinda, yeah. Then the peripheral lymphoid organs, think lymph nodes, tonsils, the spleen. These are like the field stations, filtering antigens, letting immune cells circulate and meet up. The thymus, for example, is super important for T lymphocyte maturation. But interestingly, it shrinks quite a bit as we age, which impacts T cell function later in life, something to keep in mind.
Okay, good point.
And the cells of the immune system, it's quite a team. First, mononuclear phagocytes. These include monocytes that turn into macrophages. They're the engulfers, the antigen presenters. They basically grab the bad guys, process them, and show bits to other immune cells to get things started.
Like the intelligence agents.
Kind of, yeah. Then lymphocytes. Your B and T cells? B cells turn into plasma cells and make antibodies. That's your humoral immunity. T cells make up most of the lymphocytes floating around. They're key for cell-mediated immunity fighting things inside cells like viruses, tumor cells, fungi. Within T cells, you have T cytotoxic, CD8 cells, the direct attackers, and T helper, CD4 cells, which are like the generals, coordinating the whole
The
response.
CD4, like the ones affected in HIV.
Exactly, which shows how critical they are. Then you have natural killer NK cells. These are cool. Large lymphocytes. They don't need to be formally introduced to a threat. No prior sensitization needed. They're just on patrol, taking out virus-infected cells and tumor cells. Surveillance specialists.
Wow, okay.
And finally, dendritic cells. These are master antigen capturers, often found right where we meet the environment, like the skin. They grab antigens, travel to lymph nodes, and activate the T cells. Really important initiators.
Got it. So it's a whole coordinated effort.
Absolutely. Like, picture a virus invading, like in figure 14.2 in the book. It's a cascade. A macrophage grabs the virus, shows its antigens. A T helper cell sees this, gets activated, releases cytokines like IL-2. This is the call for backup. More T helper, T cytotoxic, and B cells multiply. T cytotoxic and NK cells go destroy infected cells. B cells pump out antibodies that bind the virus, marking it for destruction. And crucially, memory B and T cells stick around. So if that virus comes back, bam, much faster response. It's really elegant.
It really is. And central to that humoral defense are the actual weapons, the 5 classes of immunoglobulins and antibodies. Let's quickly run through them. IgG, most common one, found in plasma interstitial fluid. It's the only one that crosses the placenta, which is huge for newborns. It's your main antibody for secondary responses, long-term protection.
Workhorse.
Yeah. Then IgA, this one hangs out in body secretions, tears, saliva, breast milk, gut lining. It guards the mucosal surfaces, like a bouncer at the entrances.
Protects the gates.
Right. IgM, this is the first responder, the first antibody made when you first encounter something new. Also involved in ADO blood type reactions.
The initial wave.
IgD. Found mostly on B cell surfaces. Seems to help activate B cells, but its role is maybe less understood. And then IgE. Tiny amounts, but incredibly powerful. This is the one involved in allergic reactions, especially anaphylaxis. Also helps fight off parasites. It's like the hypersensitive alarm system.
And when that alarm goes haywire, you get allergies.
Exactly.
Now, these antibodies and cells don't just figure things out on their own. They communicate using chemical messengers called cytokines. These are soluble factors, proteins really, secreted by white blood cells and others. They're the immune system's text messages, telling cells to grow, change, secrete things, or, get active. We group them into types like interleukins. They modulate immune responses. Colony-stimulating factors, or CSFs, they regulate blood cell production. And interferons.
Interferons, those sound from the antiviral, right?
Yeah, exactly. They have antiviral and immunomodulatory effects. The mechanism, like shown in figure 14.4, is pretty neat. A virus-infected cell releases interferon. It doesn't kill the virus itself, but it warns nearby cells. Those cells then make antiviral proteins that block the virus from replicating inside them. It's a neighborhood watch system.
Clever.
And clinically, you'll definitely see cytokines used therapeutically. Think erythropoietin, or EPO, for anemia to boost red blood cells, or GCSF, like Neupogen, to boost neutrophils in patients with neutropenia, often after chemo. That comes from table 14.4 in Lewis's.
Right, helping the body rebuild its defenses.
Exactly.
So pulling this together, we have these 2 big picture immune responses, humoral versus cell-mediated immunity. Understanding the difference is really key for nursing students. Humoral immunity, that's antibody-mediated, mostly B cells making antibodies. Great against bacteria, extracellular viruses, like fighting off strep throat. Targets things floating around outside cells. Then cell-mediated immunity. This involves T cells, macrophages, NK cells. It's the specialized force against threats inside cells, viruses hiding in our cells, fungi, even tumor cells.
Yeah.
And critically, it's the main driver behind transplant rejection. That's a huge one.
Absolutely.
The difference is also in the timing and memory, like shown in table 14.5 and figure 14.5. The first time you see an antigen, the response, mostly IgM, is slower. But the second time, thanks to memory cells, the response is way faster, much stronger, lasts longer, and it's dominated by IgG. That's the basis for vaccines working so well.
Right, that secondary response is powerful. Now, something really important for nurses to consider is age, the aging immune system, or immunosenescence. Immune function generally declines with age, so older adults, they're more susceptible to infections. Bacterial pneumonia is a big one, and also to cancer. Their response to vaccines like the Flecia is often weaker, fewer antibodies produced.
Why is that?
Well, a key factor is that the thymus gland, where T cells mature, shrinks significantly with age. So fewer new T cells are made. This can lead to something called anergy, where the immune system doesn't react properly to antigens it should recognize. So clinically, think about this. An older patient might have a negative PPD skin test for TB, even if they've been exposed, just because their T cell response is weaker. You can't always rely on it as strongly.
Wow, okay, that's a crucial assessment point. So the system can weaken, but what about when it goes
Yeah.
haywire, malfunctions? We're talking altered immune responses, either at under-response, that's immunodeficiency, or at over-response. And that leads to hypersensitivity or autoimmune diseases.
Yeah.
Let's say hypersensitivity reactions first. Basically, overreactions causing tissue damage. Four main types.
Right. And let's focus first on type I, IgE-mediated reactions. These can range from annoying allergies to life-threatening anaphylaxis. The mechanism is fascinating. First, exposure to an allergen. Your body makes IgE antibodies. These antibodies stick onto mast cells and basophil cells packed with chemicals like histamine. Then, the next time you encounter that same allergen, it binds to the IgE on those cells, triggering them to dump their contents. Degranulation.
Releasing all those potent chemicals.
Exactly. Histamine, leukotrienes, prostaglandins, they cause vasodilation, increased capillary permeability, smooth muscle contraction, all the allergy symptoms.
And the worst case is anaphylaxis.
Yes, anaphylaxis, systemic, life-threatening, happens fast within minutes. Okay, clinical scenario time. Imagine you're caring for a patient, JS. They just started an IV antibiotic. Suddenly, they report chest tightness, they're coughing, they feel dizzy, maybe wheezing. Their BP drops to 164, pulse is racing at 124. What's happening?
It sounds like anaphylaxis.
Yeah.
Airway, breathing, circulation, all compromised.
Absolutely. You'd see bronchial constriction, severe dyspnea, maybe airway obstruction from swelling, vascular collapse leading to shock, that rapid weak pulse, hypotension. It's an emergency. Common triggers. Lewis's table, 14.9 points to drugs. They're actually the leading cause of anaphylaxis deaths. Insect stings, foods like peanuts, shellfish, also latex, blood products.
Scary stuff.
Definitely. Then you have the less severe, but still problematic, atopic reactions. Atotopy is that inherited tendency towards allergies. Leads to common stuff like allergic rhinitis, hay fever, asthma, atopic dermatitis, eczema, like in Fig 14.8 with those itchy skin lesions, urticaria, hives, itchy wheals, and angioedema. Angioedema is like hives but deeper swelling, often around the eyes, lips, throat, that can be dangerous if it affects the airway, like the lip swelling shown in Fig 14.9.
Right. Still needs careful management. Okay, so that's type 1. What about the others? Briefly, type 2, cytotoxic and cytolytic reactions. Here, IgG or IgM antibodies bind directly to antigens on a cell surface, causing that cell to be destroyed. The classic example is an ABO blood transfusion reaction. Wrong blood type. Antibodies attack the red blood cells. They break open. Hemolysis can cause kidney failure.
Yeah, direct cell killing.
Type 3, immune complex reactions. This is different. Antibody complexes form, but they're small, they circulate, and then get stuck in tissues, like in the kidneys, joints, skin. They deposit there and trigger inflammation. SLE, lupus, and rheumatoid arthritis often involve these kinds of reactions.
Deposited complexes causing trouble.
And finally, type 4, delayed hypersensitivity reactions. Key thing here. This is cell-mediated. No antibodies involved directly. It's T cells and macrophages causing the tissue damage, but it takes time, like 24 to 48 hours to show up. Think contact dermatitis from poison ivy, that rash you see in Fig 1410, or the reaction to a PPD test for TB, that delayed bump.
Right. It takes a day or two. So, managing all these starts with good nursing assessment. For allergic disorders, you need a really detailed history. Family history, allergy specifics, what, when, how bad, treatments tried, reactions to meds, environmental factors. Objectively, you're looking closely: eyes, ears, nose, throat, skin, respiratory system. Lewis's table, 14.3, mentions signs like allergic shiners, those dark circles, or the allergic salute crease on the nose. Little clues.
Got it. Thorough history is key. What about tests?
Diagnostics can include blood tests, a CBC, looking for high eosinophils, maybe serum IgE levels. But to pinpoint the specific allergen, skin testing is often used. You apply tiny amounts of allergens via scratch, intradermal injection, or patch. Look for a wheal and flare reaction. But critically important nursing priority: never, ever leave a patient alone during skin testing. The risk of anaphylaxis, though small, is real. You need emergency equipment ready: epinephrine, antihistamines, oxygen.
Absolutely critical safety point. Okay, so if the worst happens, emergency management of anaphylactic shock. Speed is everything. First, recognize the signs. Then, maintain a patent airway intubation might be needed. Administer drugs. Epinephrine is number 1, IM route preferred, mid-outer thigh. Oxygen high flow. Treat for shock. Position them recumbent, elevate legs, rapid IV fluids, normal saline, Maybe vasopressors if BP stays low, and continuous monitoring. Vitals, respiratory status, O2 sat.
And for patients on beta blockers, epinephrine might not work as well, so glucagon might be needed.
Good point. Let's circle back to JS, our patient with the antibiotic reaction. Chest tightness, wheezing, hypotension, tachycardia, the orders come. Epinephrine, IV diphenhydramine, Benadryl, 4-week saline bolus, positioning. As the nurse, you need to know the why. Epi reverses bronchoconstriction and vasodilation. Diphenhydramine blocks histamine effects. Saline combats the shock from vascular permeability. Elevating legs helps venous return. It all works together, fast.
Precisely. Understanding the rationale guides your priorities. Now, beyond emergencies, there's chronic allergy management. This is a lot about education, helping patients identify and avoid their triggers. Lifestyle changes, stress reduction, maybe environmental controls, air conditioning, HEPA filters, dust mite covers, and huge for patients with severe allergies, especially insect stings. Epinephrine autoinjector education. From table 14.1, key points are: always carry 2 doses, know how to use it, mid-outer thigh, 90 degrees, hold for a few seconds, can go through clothes, tell family friends, check expiration dates, and the absolute must-do: call 911 and go to the ER immediately after using it, even if symptoms improve. It can wear off, or a second reaction can occur.
Crucial teaching point. What about ongoing drug therapy?
Yeah, several classes are used. Antihistamines block histamine. Sympathomimetic decongestants like pseudoephedrine or epinephrine in emergencies. Corticosteroids, especially nasal sprays for rhinitis, reduce inflammation. Antipyretics for itching. Mast cell stabilizers like cromolyn prevent mediator release. And leukotriene receptor antagonists, or LTRAs, like Singulair block inflammatory pathway. For some people, when avoidance and drugs aren't enough, there's immunotherapy or allergy shots.
How does that work?
The idea is to slowly introduce increasing amounts of the allergen extract. This helps the body build up blocking IgG antibodies. These IgG antibodies then intercept the allergen before it can bind to IgE on mast cells, preventing the reaction. It's especially good for things like bee sting allergies. You have SCIT subcutaneous shots, usually weekly or biweekly, long-term commitment. Or SLIT sublingual, under the tongue, often daily at home, more convenient for some.
Okay, but shots still carry risk.
Oh, definitely. Still a risk of systemic reactions, including anaphylaxis, especially with SCIT. So, nursing management is key. Emergency gear must be ready. Careful record keeping of dose and any previous reactions. Inject an extremity away from a joint so a tourniquet could be applied if needed. Rotate sites. And the big one: observe the patient closely for 20 to 30 minutes after the injection in the clinic, and teach them about possible delayed reactions later on.
Got it. Okay, let's shift to a couple of specific challenges. Latex allergies. Seems like we hear more about these. 2 types, right? Type 5e is a delayed contact dermatitis from the chemicals. Type I is that immediate IgE-mediated reaction to the rubber proteins themselves, potentially causing anaphylaxis. And there's that weird latex food syndrome connection.
Yeah, it's interesting. Some proteins in latex are similar to proteins in foods like bananas, avocados, kiwis, tomatoes. So someone allergic to latex might react to those foods too.
Huh. So, nursing management for latex allergy. Primarily prevention, I assume. Table 14.13 probably covers this. Using non-latex gloves, powder-free gloves, cleaning equipment, recognizing symptoms early, patient education on avoidance, wearing a medical alert, carrying an EpiPen.
Exactly. Avoidance is key. Now, another area a bit more controversial is multiple chemical sensitivity, MCS. This is really a subjective diagnosis. Patients report various vague symptoms: headache, fatigue linked to low-level exposure to chemicals like perfumes or cleaning supplies. There are no objective diagnostic tests, so it's controversial. Management usually involves helping the patient avoid perceived triggers and sometimes psychotherapy.
Okay, a complex issue. Now, let's flip the script entirely. What happens when the immune system attacks the body itself? Autoimmunity. Losing that self-tolerance we talked about earlier, the immune system sees self as non-self and attacks. Creates autoantibodies, autosensitized T cells, causes tissue damage. Factors involved: genetics play a role, like certain HLA types. Infections might trigger it, maybe drugs, hormones, it's complex. And autoimmune diseases often cluster together in individuals or families.
Right.
Systemic lupus erythematosus, SLE, is a prime example. Autoantibodies form immune complexes, like we discussed in type 3 reactions. These deposits all over skin, joints, kidneys, brain, causing widespread inflammation and damage.
A classic systemic autoimmune disease.
For some of these conditions, treatments like therapeutic apheresis and plasmapheresis can be used. Apheresis basically separates blood components. Plasmapheresis specifically removes plasma, getting rid of those harmful autoantibodies or immune complexes. They take out whole blood, spin it, remove the plasma, and return the cells with replacement fluid like saline or albumin.
So filtering out the bad stuff.
Essentially, yeah, nursing considerations. Monitor closely for side effects. Hypotension is common because of the fluid shifts. Also, citrate, used as an anticoagulant, can bind calcium, leading to hypocalcemia. So watch for tingling, muscle cramps, dizziness.
Good points. Now, the opposite problem. Immunodeficiency disorders. Here, the immune system is impaired, it fails to protect adequately. Two main categories. Primary immunodeficiency is rare, usually genetic, involves improperly developed immune cells, often serious. Secondary immunodeficiency is much more common. It's acquired caused by other illnesses or treatments.
Like what kinds of things?
The most common cause by far is drug-induced immunosuppression. Think chemotherapy drugs, corticosteroids, used long-term for autoimmune diseases or transplants. These globally suppress the immune system, which of course leads to a huge increase in the risk of infections. Opportunistic infections become a major concern. Other causes: age itself, malnutrition, chronic diseases like HIV/AIDS, certain cancers like lymphoma or leukemia, diabetes, burns, trauma, radiation therapy. Lots of things can weaken immunity.
So if your patient is on chemo or has lymphoma or is on high-dose steroids, infection prevention and early detection become paramount nursing responsibilities, right?
Absolutely paramount. Vigilance is key.
Okay, connecting genetics back to immunity. Let's talk human leukocyte antigen, HLA system. These are proteins, antigens on the surface of almost all our cells. They're like the body's unique ID card, highly specific to each person inherited from parents, and they're absolutely crucial for transplantation. Matching HLAs between donor and recipient is vital to minimize the risk of the recipient's immune system rejecting the new organ or tissue.
Exactly. We inherit one set of HLA genes, a haplotype, from each parent. That's why siblings often have a better chance of being a close HLA match than unrelated individuals. We also know certain HLA types are associated with an increased risk for some autoimmune diseases, which is interesting.
Right. So this leads us directly into organ transplantation. Incredible medical advancement.
Huge. We can transplant kidneys, hearts, lungs, livers, pancreas, intestines, bone marrow, corneas. Donor sources can be deceased individuals or living donors, especially for kidneys or parts of a liver. There's a complex waiting list system. Donor-recipient matching is multifaceted. First, ABO blood group compatibility is essential. Then, HLA typing, looking particularly at HLA-A, MATCH-Lee, and TASHR antigens. The more matches, generally the better the outcome. We also test the recipient's blood for panel of reactive antibodies, PRA. This measures their sensitivity to various HLA antigens. A high PRA means they're highly sensitized, maybe from past transfusions or pregnancies, making it harder to find a compatible donor. And finally, the cross-match. This directly mixes donor lymphocytes with recipient serum. A negative cross-match is good, no preformed antibodies against the donor. A positive cross-match means the recipient does have antibodies, indicating a very high risk of immediate rejection. It's usually a contraindication, especially for living donors.
So lots of steps to find the best possible match. But even with good matching, rejection can still happen.
Yes, transplant rejection is fundamentally a normal immune response against foreign tissue. The recipient's immune system recognizes the graft as non-self. Three main types. Hyperacute rejection. This is immediate, within minutes to hours, maybe up to 24 hours. Caused by pre-existing antibodies in the recipient binding to the donor organ's vessels. Leads to thrombosis, organ death. No treatment, organ must be removed. Rare now because of cross-matching. Acute rejection. This is the most common type, usually occurs in the first 6 months post-transplant, can be cell-mediated, where the recipient's T cells attack the graft, like in figure 1442, or humoral, where antibodies develop against the graft. It's often reversible with increased immunosuppression. Chronic rejection. This happens slowly, over months or years. It's an irreversible process involving fibrosis and scarring of the organ tissue, leads to gradual loss of organ function. Treatment is mainly supportive.
Okay, so preventing rejection requires lifelong medication.
Yes, immunosuppressive therapy is generally lifelong, and it's a constant balancing act. You need to suppress the immune system enough to prevent rejection, but not so much that the patient gets overwhelmed by infections or develops drug-related cancers. Plus, these drugs have significant side effects. Standard practice often involves triple therapy, usually a calcineurin inhibitor, a corticosteroid, and mycophenolate mofetil. Figure 14.14 shows where different drug classes act. Key drugs include calcineurin inhibitors like tacrolimus, Prograf, and cyclosporine, Neural. They are workhorses but have many side effects and require drug-level monitoring. A critical nursing point for these: avoid grapefruit and grapefruit juice. It inhibits their metabolism, leading to toxic levels. For mycophenolate mofeal, Cellcept, if given OFI, remember it needs specific reconstitution with D5W only and infusion over at least 2 hours. Never give it as an IV push. These details matter for safety.
Absolutely. Details save lives. Okay, one last specific complication. Graft versus host disease, GVHD. This sounds backwards. Here, the graft of the donated immune cells, usually in a stem cell transplant, attacks the host body.
Exactly. It happens when an immunodeficient recipient gets immunocompetent donor cells. The donor T cells recognize the recipient's tissues as foreign and attack. Onset is typically 7 to 30 days post-transplant. Main targets are the skin, rash, liver, jaundice, elevated enzymes, and GI tract, diarrhea, pain, bleeding. The biggest problem in GVHD is the profound immunosuppression, leading to high risk of infection. Treatment is difficult, often involves increasing immunosuppression, which worsens infection risk. It's a tough situation.
Wow, okay. We have certainly covered a massive amount of ground today, from, the tiny dance of antibodies all the way to the huge complexities of organ transplants and GVHD. We really hope listening to this helps you feel much more confident about the immune system, just how vital understanding it is in nursing.
Absolutely. I think the main clinical takeaways for you listening are: always think about that delicate immune balance. Learn to recognize early signs of problems like anaphylaxis. Be incredibly thorough in your patient assessments. And understand why nursing interventions matter, whether it's emergency drug administration, careful monitoring, or patient education for chronic conditions or immunosuppression. Your knowledge makes a real difference.
So what does this all mean for you? Well, the next time you're looking at a patient's chart, assessing someone, or even just thinking about health, pause and consider that silent, intricate army working inside. How might that medication they just started, or a past infection, or just the fact they're getting older, how might that be influencing their immune defenses right now, thinking that way? It changes how you practice. Thanks so much for joining us for the deep dive.